This is Mythbusters. We wanted to share some information about the real life of emergency medicine with all of you. My name's Hillary Fairbrother, and I'm going to have everybody who is going to be presenting tonight briefly introduce themselves. Let's start with Dr. Barnes.
Hi, Bobby Barnes. So one of the APDs out at Baylor University Medical Center in Dallas, Texas, and get to work with Dr. Brewer, amazing guy.
Dr. Kraut.
Hi there, Natasha, and virtual world. I'm Aaron Kraut. I'm the program director in Madison, Wisconsin at the University of Wisconsin.
Dr. Morrissey.
Hi, I'm Kirsten Morrissey. I'm a pediatric emergency medicine attending at Albany Med, and I'm also division chief for our forensic medicine division.
Dr. Brewer.
Hey, Natasha, I'm Jonathan Brewer. I'm another one of the APDs at Baylor University Medical Center in Dallas with Dr. Barnes.
My name's Hillary Fairbrother. I'm the Assistant Dean of Pre-Clerkship Education at UT Health Houston in McGovern and Houston, Texas. So welcome today. We're excited to kind of share this topic with you. And really, we just know that there is a lot of information and there's a lot of things that people talk about when it comes to emergency medicine and the lifestyle and the burnout and all of these different aspects of our specialty. We wanted to give students who are thinking about a prospective career in emergency medicine an honest and just like real life take on what we think are some of the best parts of our lives and what are some of the hardest parts of our life. It is an amazing career. I will start it off with that. I am a very happy, almost 20 years in, which is kind of crazy to think about. But I am a very happy emergency physician. I practice 50% peds emergency medicine and 50% adult in an academic setting. And it is an amazing career that has really enabled me to do everything I ever wanted to do within medicine and practice kind of, I think the way at our core, a lot of us really went to med school for is to help everyone, anytime, anywhere, any kind of patient and everything like that. So without further ado, we will move forward and start our talk with some common misconceptions and a reality check on emergency medicine. We'll start with burnout.
I can start off. Natasha, I'm sure every medical student, every resident and attending has heard of this concept. It's kind of perpetuating throughout medicine as a whole. And I think, if we're going to talk seriously about emergency medicine, also know may be listening into the recording, this is a really important topic to emergency physicians. EM has some very high burnout rates. About last recorded survey that went out was about 60% of emergency physicians feel some semblance of burnout in their career. And so it is something that, again, is an epidemic in medicine, but there are a lot of contributing factors, I think, that specifically relate to emergency medicine. We are a shift work based specialty. I personally love that aspect of emergency medicine, but it is shown that the circadian disruptions can contribute to a sensation of burnout within your personal life as well. We see high patient volumes. We have high expectations. So not even just throughput, and by that, just kind of moving people through the emergency department. There's high expectations on the emergency department. Every year, I think with EM, I always call us the gatekeepers of medicine. And every year, it seems like our scope of practice expands a little bit more. And I think that's one of the things that can contribute, staying on top of the latest literature. There's challenging consultant interactions at times. I think this does vary a lot depending on the place you work. And then also patient satisfaction pressures. I think that when I was initially growing up was the show that everyone loved. And now there's a new show that we were just talking about called The Pit. And I think they do a really good job of demonstrating some of the pressures that emergency physicians and emergency nurses and staff all face. Now, we do want to talk a little bit about ways that we combat burnout in emergency medicine. I think definitely talking about work-life balance, prioritization, talking about managing your personal life. I think that having good hobbies outside of medicine really do help with some of the burnout rates. I myself am an avid purveyor of Texas barbecue. And so that is my hobby. And it's something that I do on the side just to really enjoy my life outside of work. Also, working with family. All of us here are in academia, and which we personally love. We find passion out of working with students, out of working with residents, and it gives diversity to our career. And I would argue that's one of the biggest ways to combat burnout as well, is that we're not doing the same thing day in and day out, and we get to really see the fruits of our labor as the students, our residents, and our other mentees grow. And so I think there's a lot of ways to combat burnout. Again, it depends on where you work, the type of environment you want to work in. And then also, again, just managing your work-life balance in and out of medicine. But I can tell you that I feel very fulfilled in emergency medicine. I love being an ER doc, and I will hopefully be one for a very long time.
Okay, I'm going to get to talk a little bit about the workforce myth and maybe give a dose of reality here. This has been a topic of interest of mine for a few years, and so I was really excited to get to share this piece on the presentation. So, you all who are listening may or may not have read or at least heard about this big workforce projection study that came out in 2021. And the headline was there's going to be no EM jobs in 10 years. And there's a lot of factors that played into that workforce study. But bottom line, there are a huge set of problems with the study. And this is not at all the reality that we've seen with our graduates over the last 5 years. And in my opinion, it's not the reality we're going to see in 10 or 15 years down the road for a ton of reasons. Number one, COVID fundamentally altered a ton of things in our life, not just the way medicine's practiced and how people work, but I think folks have a very different relationship with their careers as physicians now than they once did. And, a lot of the data that went into preparing this workforce report, which has since been much maligned with good reason, is people no longer go into emergency medicine and want to work 160 hours a month for 35 years. That just people aren't doing that anymore. It's not the way people live. And so when you're projecting based on that type of data, of course it looks like there's going to be no jobs in the future because we just keep minting more and more emergency physicians. But the reality is that many folks, in my personal experience, and when you look at the literature and they study this, people are looking for, part-time work. They're working for shorter amounts of time in emergency medicine. They're diversifying their careers, to Jonathan's point earlier. And, all that leads to a huge demand actually for an EM workforce rather than a shortage. People are also getting older. These emergency physicians who've been out for 15, 20, 25 years. The practice of EM is different now than it was back then when they started. And some of those pressures too cause people to reduce the number of hours they work or diversify the types of things that they do. It's really tough when you're moving 35, 40 patients through an ED in 9, 10, 12-hour shifts. It's really tough to do that multiple days a week for multiple years in a row and have no reprieve. This last piece we wanted to highlight, who knows what's going to happen with the new ACGME proposed guidelines for EM residencies and moving from a 3-year to a 4-year model. But, there's the potential too that there's going to be a big period in time where we're not putting out a ton of new grads. And I think the system relies on new graduates being churned out year over year just to meet the current demand. So that's the myth. The reality, and again, this is borne out in data on physician attrition rates across our specialty. The job market is incredible right now. My grads are getting multiple really nice job offers and having to make difficult decisions about which one to take. They're being actively recruited in a way that probably most of us were all around the same age. Maybe I'm on the older end, but that wasn't the case when I was looking for a job out of residency. You'd be really lucky to find a really desirable job. And now folks are calling me as a program director and saying, hey, we tried to hire one of your grads a few years ago. They were awesome. Do you have anyone that wants to come and work for us? So all that says to you folks, sure, this is something we need to care about and pay attention to in the long term. But if you're going to enter this specialty anytime in the next few years, I think the job market in the horizon is super bright for everybody.
All right, so I think this slide is mine here. And so just, some of the things that you'll hear out there is the risk of litigation, right? And so lawsuits, something that's scary and things that you don't really want to think about as you're trying to plan your career kind of moving forward. But, what we do know is that about 75% of EM physicians over the course of their career will have at least a claim made against them at some point. The good news is about 2/3 of those will be dropped before they ever go anywhere. And then about another quarter or so will end up actually kind of settling before they go out into the actual court world. And if something actually does, only about 8% of those cases ever actually make their way into the courtroom. So it's not super common overall. Most of these cases don't end up resulting in payouts, which is overall the good news. There are a lot of kind of state level advocacy that's going on. Love Texas for a number of different reasons. I grew up in Arizona, but moved out here and have been here for about a decade. And so at this point, it's really ongoing looking at, what else can we do to fix things and to make it better, easier for physicians to practice good, high quality, evidence-based emergency medicine. And, we have tort reform here in Texas, which is absolutely amazing. And so hopefully we'll start to see that spread across the United States. There's a number of other things, and kind of making a quick kind of touch on different malpractice coverage. These are things that I don't think you need to worry about too much now, but certainly when you get to actually getting a job, there's different options that are out there. And the biggest thing is that you always want to have coverage for whenever you are seeing a patient, and knowing that, when you're seeing a patient, it can take years sometimes to actually see those claims being made and having a case actually filed against you. And different terminology such as tail coverage is always very important to have. And we've seen some issues in the past where some of these bigger corporate groups have shut down and left a lot of ER docs without any kind of tail coverage to protect them against litigation. And so these are just things to be aware of. And I don't think it's something that should really dissuade anyone out of the field, but it's the reality of what we have to deal with.
So it's my turn to talk about ED overcrowding and boarding. And that is something that they show on the pit. And that is something that is a national crisis in our specialty. It is just really impossible to get our patients who we have admitted to the hospital out of the emergency department. And many of them will end up waiting in the emergency department for hours, sometimes even days, and depending on some special cases, even weeks to months, especially when it pertains to patients, particularly pediatric patients who are boarding and waiting for an inpatient pediatric psychiatric facility bed. That is a patient, depending on where they are in the country and what kind of resources are available and what their particular needs are, who very well might spend weeks to months in the hospital and potentially in the ER waiting for placement. This is due to so many different things. And if you talk to anybody, you're likely to hear at least 3 or 4 reasons why they think that boarding is a problem. But I think it's safe to say that it is affecting our practice. And it is a negative effect. When we look at our patients, if we hold them first, boarding is negative on the healthcare of our patients. Our patients do poorly when they are boarding in the ER. They do better and have better outcomes, both morbidity and mortality, when they are more quickly able to get to their standard of care that they need. And that's something that kind of makes sense, because if you think of, grandma who fell and broke her hip, she's relatively stable. She needs to go to a medicine floor bed, and maybe she needs a Foley catheter, and she needs to have someone help her when she needs to go to the bathroom, and she needs to be eating when she's supposed to, and then NPO when she's getting ready for surgery. And, all of these little things that aren't like crazy pressors and crazy medical care, but those kinds of things are really important. And if our grandma stays in the hallway and gets delirious because the lights never go off and the noise never goes down, and she is awake for 18 hours, and she then falls trying to crawl her way out of bed, and no one's watching her as well as they should have, and no one's helping her when she needs to go to the restroom, and no one's turning her or moving her enough, so she gets a bed sore. There are just all sorts of negative consequences, even to patients who aren't critically ill and needing an ICU bed. I don't know about all of you. I actually think that some of those patients are the ones that got really all of my attention when they're in the ER for a very long amount of time, because they do take so very much attention. And it's often the patient who seems like they could wait, who has to wait, 3 or 4 hours for their blood to be drawn because the nurse is with me, with a critically ill patient in the room next door. Overcrowding really is an issue. It is due to the fact that hospitals get paid for admissions, whether the patient stays in the ER and never goes to a bed, or whether they're in a bed in a minute from when we admit them. It has to do with the fact that hospital staffing and efficiencies are basically beds that are empty. They try not to staff. And so then they stay at this very full place. Even if they have empty beds, then they'll close off part of floors and things like that, and do that to save money. So they're not paying nurses and techs and all of the care that goes into a bed in the hospital to just sit there and be empty. It has so many different factors, and therefore we know that the solution is most likely going to be complicated. And we are working with both the federal and state governments to figure out what solutions can be from a systems level to really help us with this crisis. Again, what impact this has on our day-to-day, besides just the fact that we are, obviously troubled by the fact that our patients are not getting the care, not getting the timely care that we wish they would, especially when we're really overcrowded and boarding many patients. It also causes us to see patients in non-patient areas. I bet almost every single one of these physicians on this call or on this session today have seen patients in the waiting room, have seen patients in the hallway. I'm sure you can imagine like doing a genital exam and on a hallway patient requires a shuffling of a patient or putting up of a screen or trying to drape something, or maybe a medical student is holding up a sheet. There's all sorts of things that we will do so that we can do our best to see as many patients as quickly as possible. And when our beds are full of patients who we've already seen and who are already admitted, and maybe if we're lucky, someone else is taking care of, then we are seeing patients in very non-traditional areas. And that can lead to, maybe not the best abdominal exam if the patient isn't lying flat. And maybe we miss something, or we ask about drug use, but somebody doesn't really feel comfortable telling us about their drug use or their history of mental health issues in the hallway surrounded by other patients and their family members. Without that privacy, it is definitely a really tough place to practice. Current solutions, again, we are looking at everything from individual hospitals to the federal government to help us, and we'll get there. I know we will, but it is taking more time than I wish it would, and I do think that this is a big factor in emergency medicine practice of today, both for our faculty and for our trainees and residents.
Yeah, so I think in general, I remember being a medical student resident and thinking, I have no idea how the pay and reimbursement stuff works, but we'll give you kind of a quick overview here. Again, this is things to think about kind of in the future, but in general, most places are some kind of structure built out around this. And, we've got RVU based hourly wage and then kind of a split the difference between the two. I think the easiest one to think about is hourly wage. If you've ever held a job, this is exactly what it is. You're kind of contracted for a set payment per hour. And so you work your number of hours in a month and you collect X number of dollars at the end of that. The RVU based model, everything that we do in medicine, RVUs or relative value units are how we are paid. And seeing a patient, writing a note, kind of going through your medical decision making complexity, that generates a certain number of RVUs. Procedures that you do, central lines, intubation, orthopedic reductions, things like that, those have RVUs assigned to them as well. Current standing, I believe, is about $33 and some change per RVU. And so at the end of a month or end of a pay period, you generate so many RVUs, and you can multiply that by $33 or whatever the going rate is currently for RVUs. And at the end of that, you collect that paycheck for that period of time. The difference between these two is really, with an hourly wage, as long as your hours are pretty set month to month, you can expect that your paycheck is going to be very similar and almost kind of a salaried type of position. With RVU, it's more of this kind of, eat what you kill model is kind of the phrase that tends to be out there. And so if you're very efficient, you're very fast, and you bill well and you document appropriately, you can be very reimbursed. If you're a slower doc, you like to take your time with patients, you're not super efficient, you may have a lower RVU. And so for some people, RVU based locations are not the best, and they would be better working at an hourly type of place. And then there's something in between, right? And so there's a lot of places that have this hybrid model. They give you a baseline hourly rate, and then they have some kind of a productivity incentive or RVU strategy on top of it. And it just really depends on what you're looking for and what they have at the end of it. And so those are the different pros and cons there. Some of the other things is if you go back 20 plus years ago, the world of emergency medicine was much different. You had a lot more democratic groups and partnership models where, you put your time, your sweat equity into it, and you became a partner within a group. And then you all got to split the profits as a total. And in those models, you really have a lot of influence over what you did. You had a lot of autonomy, able to practice emergency medicine in the way that your group thought was best and really kind of work directly with the hospital system. This day and age, I would say the majority of things are kind of moving towards these corporate management groups. And some of them, I think, tend to have devil horns, depending on who you're talking about. Others tend to do an okay job at it, but it's just the reality of what we're kind of dealing with. They tend to be able to manage a lot of different contracts across a big area. And so because of that, they have the ability to kind of leverage a little bit more when it comes down to buying with insurance companies for reimbursement. And so that's the reason that our kind of market has changed recently over the course of the past couple decades. And then you've also got this other additional entity, which is folks that these corporate medical groups, that management groups that use private equity can be very dangerous. We've seen at least one very large one in recent years file for bankruptcy, and they're using a lot of debt to kind of prop themselves up. They're also, you get into a mix of business and medicine, and a lot of times those things are at odds. And it really has to do with your own ethics, morals, whether you want to work for a group like that or not. And it's a very complex situation, and something that I always tell our residents and our graduates to really think heavily on, and think about how much your overall practice of medicine is going to be managed day to day. But in general, corporate medical groups have good pros and some cons, and some have a lot of cons. And so it's just something to take into consideration.
Telemedicine and observation medicine are some interesting parts of emergency medicine these days. And it's pretty cool in many ways to see how different practice strategies and different clinical practice types have entered into medicine. I believe one of the prior speakers was talking about how our scope of practice has continued to increase, right? I now see patients in the waiting room. I take care of ICU patients sometimes for the first days, not just 6 hours of their care. I'm continually being asked to do more, and that can be pretty cool in some ways, and also can be negative if you are asked to do more, of course, with less, or do more with the same, which is, I think, honestly, what a lot of us are continually asked to do with. So this is a little bit of the future of emergency medicine. Does anybody, a show of hands, who here practices any telemedicine within your emergency medicine? I do. You guys do not. You do? Bobby does. So there is an increasing ability for emergency medicine groups to be integrating telemedicine into practice. The way this happens at UT Health Houston is we are part of Harris Health, and that is our county health system, and it is an integrated health system. So the clinics and the hospitals and the pharmacies and the labs, everybody is really owned by Harris Health. It's like Kaiser of Texas. And the way that they will save money is if a patient, instead of coming to the emergency department, can just go follow up with the doctor maybe that they needed to see after their surgery, or all of the reasons that sometimes patients come to the emergency department with a need from our complex healthcare system that really probably could have been met by another part of our healthcare system, didn't absolutely need our expertise of resuscitation and immediate surgery in the ER, and really could have been taken care of by potentially seeing their specialist or their PCP or their various different other elements and partners that we have throughout the healthcare system. So what I do is keep patients out of the ER. They call the Ask My Nurse hotline, and I talk to them and I say, okay, you should go to the ER. You look like you're having a stroke. Please go now. Or, hey, I think maybe you just have a urinary tract infection. Why don't you go to the lab, give them a urine sample. We'll follow it up. We'll give you antibiotics if you have a UTI or pneumonia, get a chest x-ray. And that's a pretty unique way, I think, of practicing emergency medicine. But what it's allowed me to do is, before my youngest child was born, I was told I was no longer safe as a very pregnant lady, and very old pregnant lady at the time, to work clinical shifts. We have a very busy high acuity shop where I work, and they didn't want me running around the trauma bay anymore. They didn't want me delivering that baby early. And so I pushed all my time into telemedicine and was able to work from home, both before I had my kiddo and I didn't have to go into early labor, yay. And then also, after many of our faculty have small children at home, they'll choose to do a higher percentage of telemedicine shifts so they can be at home with their family and have a more normal, 9 to 5, 8 to 5 kind of schedule. So it does expand our practice. And if done, can really keep people out of the ER if that's what your health system is incentivized to do, or allow us to get more care to more people at home. We have many patients who have real transportation issues and to get into us. There is also a concomitant growth in observation units for hospitals. There are many hospitals, one of which I used to work at, NYU, which is doing this very well, where, pretty much everyone is admitted to observation or the ICU. And a lot of observation units are also run and managed and staffed by people who have training in emergency medicine. Sometimes they also have training in internal medicine, but sometimes they are just in emergency medicine. And observation is meant to be essentially like a very short hospital stay. So maybe a chest pain rule out with a quick serial troponins, and then patients get a stress test of some sorts. It said you do not have things that look like you have ischemic heart disease or acute coronary syndrome, and you are safe to leave the hospital, as opposed to all of those patients being admitted to the floor or to an intermediate care unit or to an ICU in the past. So these are areas where we are practicing, which we are expanding ourselves in our practice. That is not the only way that everyone is practicing telemedicine and not the only way that observation units roll, but they are, I think, another reason when we talk about that workforce study that there are not less jobs, there are actually more and more jobs. I know at our shop, the hospital wants to expand telemedicine to 7 days a week, 7 a.m. to 11 p.m. because it's working so well. They're like, this is like the best service ever. And they want to expand it, which means we have to hire more people. This really does allow for many physicians to supplement their income if they are independent contractors and they did not sign a non-compete, and they can work in whichever way that they want. Like I mentioned, this does diversify practice. We already talked about how a lot of emergency physicians today no longer want to work in the busy ER, in the chaos, working nights and weekends and holidays. Telemedicine, observation medicine is much more of a normal schedule and allows for a concentrated hours Monday through Friday during the day, to a certain extent at least. And it does require us to broaden and advance our skills, but we've kind of shown that we can do it really well. And most observation units in hospitals are wildly successful because they are very good at getting, especially algorithmic inpatient short stay care, very quickly and efficiently. The positives.
I'm going to talk a little bit about this in terms of what I think is one of the most positive aspects of emergency medicine, but just a tail end on that, telemedicine. We actually have a contract with Department of Corrections for the state. So we do all of the telemedicine for the entire state for all of the Department of Corrections. So that's sort of another area. We don't do the traditional telemedicine that Dr. Fairbrother was just talking about, but this is another way that a lot of our APPs do the coverage, but also our physicians that either need to take time off or flexible, like working from home, will also do some of that. So that's another interesting way that we've, added some, different types of shifts for people. But I'm going to talk a little bit about scheduling, just sort of the variety of schedules and sort of aspects that go into that. Sort of one common myth in going into emergency medicine is I can pick my own schedule. And really, for the majority of emergency medicine physicians, that's not the case. We have almost 50 people in our group right now, between full-time and some per diem. And you can imagine that if 50 people tried to put in their own schedule and make their own schedule, like that would create total chaos and not be possible for our schedulers. When you think about it, about a third of the shifts are going to be day shifts, a third night shifts, a third evenings. A third of them are weekends. We actually have more evening shifts in our pool than we do day shifts because we're busier in the evening. So there's more double coverage in the evening. You're going to be working a variety of shifts, and for the rest of your life, you're going to be working, holidays and weekends and, those types of schedules. So that is sort of the reality of what we do in emergency medicine. There is some flexibility. And I think one thing that's nice, so we typically put in our requests for days that we want off, and our schedulers work around that and then sort of schedule shifts on the other days. One thing that I really liked and that drew me to emergency medicine is the lack of on-call responsibilities after shifts. So I was a pediatric resident. I hated having a pager all night long, being paged for things. And there are some folks that are in emergency medicine administrative roles that might take calls or have a paging system. And we do have a sick call system where somebody's on call for backup. But if you've got 50 people in your group, that may be once a month, once every 2 months that, we're on call for backup. And it's very uncommon to be called in for illness or emergencies. So that's another aspect that I really like about emergency medicine is I'm done, again, talking about the shift work. I'm done with my shift. I finish my charts and I'm done for that day. All that to say is that I actually do make my own schedule. I'm a nocturnist. So I have quite a bit of control over my schedule, which is the main reason that I'm a full-time nocturnist. So for nocturnists, they try to incentivize people working nights. And in some places that means you make a differential in pay and you might make a little bit more for working night shift. For me, I get a 20% hour reduction. So I work less for the same salary. And then I also get to, for the most part, choose my shifts. So there's 8 or so of us that are nocturnists, and if everybody wanted to work the same day, it wouldn't work out. So occasionally we have some, have to switch things around, but I do have a little bit more control, which is the main reason that I work full-time nights. And so I think that's, it is a possibility, but it's not the norm, but I really like having that the flexibility exists, that if I need that control over my schedule with 3 young kids at home and I can make that decision, which was a real positive for me in terms of flexing my hours and what my schedule looks like. So we can go to the next slide. In terms of, we talked a lot about just high demand of emergency medicine physicians, and I think that's going to continue into the future for sure. But that demand nationwide means that there's more flexibility in terms of the types of jobs that we can take and sort of the variety of work that we can do. So locums work is one option for people that might want to travel and are more flexible. And there's different length contracts for locums physicians. So it might be weeks or months. And then there's longer contracts that I've heard of up to a year for locums docs. That can be an option for people that are a little bit more mobile or ability to move and take those types of jobs. Per diem jobs are very common, at least in my group. So I'm in an academic center. Many people choose to do per diem shifts in a community center or sort of a more freestanding ER just to keep up those skills and just have that as, another experience. Again, keep diversifying the type of work that you're doing. People like to do that. There's people that just work per diem or part-time. So I think that flexibility is fantastic as well. And then thinking about sort of super commuting, I don't think it's really that common, but I do know people that will decide to work in another state 3 or 4 shifts in a row, or maybe do a week and then go back home and have longer breaks of time off. Lots of flexibility in terms of types of jobs, supplementing income, sort of making something work for you and your schedule, which is great. Emergency medicine by nature, it's a little bit easier to relocate and have these flexible jobs just based on the nature of the work. We don't have these large patient panels that we need to transition to another physician. We're not sort of accumulating our own patient panels, and there's not really any long-term obligation in terms of closing practices. I think that lends itself to more flexibility in general. Next slide. And we talked a little bit about that, different work models, full-time, part-time. Again, nocturnist is always an option, and I think sort of the benefits for me outweigh the negatives of circadian rhythm disturbance at this time in my life, administrative roles. And I think, the beauty of emergency medicine is, there are people in my group that have been doing it 35 years that are full-time clinical, that just love working with residents. They love shifts. There are people that work almost no clinical, work a couple of shifts a month, and they're still full-time with administrative jobs, and really sort of finding that balance that works for you so that, and then that may change over time and you might decide to move into more of an administrative role and, back away or vice versa, which it's nice to have that flexibility. And I think although it's possible in other fields, it's a little bit easier in emergency medicine to find a niche and to sort of build other types of roles, including research, advocacy work, policy, and that ability with that work-life balance to flex as needed. So I went to full-time nights after I had my 3rd child just because I needed more flexibility. I did it for 4 years and then did sort of regular work for a couple of years and just went back to nights because I needed that sort of flexibility in my personal life. I think it's really nice. I have the ability to have a week or more off every month from clinical work, which gives me time to travel and it gives me time to work on projects, sort of other academic projects in larger group like blocks of time if I want. And I also think it helps with burnout to have a longer chunk of time without being in the emergency room for me. So I think there's a lot of benefits with schedule. Another sort of positive is that sort of interfaces with, we talked about taking on more roles within EM, but you are the face of all aspects of the healthcare system. And I think that lends itself to being able to be an advocate for a variety of different, aspects of medicine right now, which is nice. I work as part of my forensic medicine division, sort of doing a lot of advocacy work for legislative stuff with intimate partner violence and physical violence and workplace violence. So that's really a nice aspect that I can branch into. Our EMS folks do a lot of community work and outreach within all of the communities and the various EMS, groups and regions. So that's great. And I think it allows you, again, to create interests that help prevent burnout and keep your career interesting at different stages in your career.
And then I'll start to wrap things up. I think that I completely agree with everything Christian said. I think one thing to add would be some of the final positives of emergency medicine are the minimal administrative burden and the critical role in healthcare. When you talk about the minimal administrative burden, I think one of the best examples that I have is, when you open the EMR and you see the in basket, right? We don't have to check our in basket every single day because there are 30 patient messages that need to be responded to. One of the best things that was mentioned earlier was that when you go home, you get to go home. And while there may be some slight things, a culture that needs to be followed up or some results that you've been copied on, really when you're off, you get to enjoy your time off. And I think that's a huge aspect of our specialty that I truly value. And I think so Dr. Barnes and I were talking recently, and he put this second point into perspective. And he told me that the best thing about EM is that he gets to intervene on the worst day of people's lives and give them the best shot at being with their families in the future. And I think that's probably the best summary of emergency medicine that I can think about. We really truly do hold the line for the entire healthcare system. We are the frontline workers. You saw that with COVID. You see that with anything and everything that comes through that door. Emergency medicine runs to it and not away from it. And so I think that does give us a strong sense of purpose moving forward. And it's one of the reasons why I would argue that all of us love emergency medicine. We love what we do. And even though there are some negatives, as there are with every specialty, and the myths that are out there, we truly love what we do, and the positives outweigh the negatives every day.
So in conclusion, like most things in life, you get what you put in. And the beauty of emergency medicine, and I always think this when I'm walking on a shift, I have a walk-up song, but it's like my drive into work song. Like I like to get in that space before I start my clinical practice. And I might be headed into a chill day and it might be a really intense environment. There might be some really high emotions from other physicians to patients' family members to patients themselves to other healthcare team members. We negotiate and we communicate just with the best of them. And sometimes it's really tough and sometimes it's really meaningful and sometimes it's really sad. And, that is the beauty. We walk in and we get what we get. But I do want to just amplify what Dr. Brewer just said, that it is a tough job, but it is the best job because we are truly, I think, at the core of what being a physician is to me, is what I get to do every day at work. I don't ask people what insurance they have. I don't only treat a certain patient population or a certain part of the body. I get to really take care of people in the way that they need to the best extent that I possibly can. And it is really a gift and a privilege to fill that role. And it's, an everly increasingly important role because we know that there are more and more people who are using the ER every year. I still remember I've worked in healthcare policy for a long time, and I was working with, as the ACA was getting created, they're like, if everybody has insurance and everybody has a doctor, no one's going to go to the ER. And I was like, are you sure that if everyone has insurance, they are not going to go to the ER? Because I think they're going to go to the ER more. I actually think that not having insurance makes people go to the ER less because it's really expensive and it could put them into terrible debt and terrible pressure. And they, if they have insurance and they can go without that fiscal stress, I feel like more people are going to go. Nope. If everybody has insurance, no one's going to go to the ER. I was like, okay. And, the ACA did allow for more of our country to have access to insurance. And sure enough, our volumes did not go down. Our role is a critical point in our healthcare environment, and it is the safety net for our most vulnerable patients, but really for everyone. And I love being part of that role. It's certainly not a perfect specialty, and we've got some real external threats. And we've got some rules that I think most people really love, that, really say we've got to take care of everyone. And that does mean that a lot of the care that we deliver is not compensated by anyone. No one's paying for it. We are just delivering. But it does allow us to practice as purely as I have found in the United States. And I do think that if you thrive in this kind of unpredictable, sometimes organized chaos, exciting environment, that emergency medicine truly might be a great fit for you. And with that, it is 6:49. I feel really bad, Natasha, because you are our only person logged on. But if you have any questions, I do want to give you the space to talk to any of us. And we're here for you. And if you're watching this online, I truly hope that if what we've said today, if it spoke to you, that you really consider a career in emergency medicine. And the best thing I would say is go find some emergency physicians and talk to them about what they do and get the real story. Don't get the story for any specialty except from the people in the specialty. All right.
Thank you for being here, and I do have a couple questions. Was wondering if you could talk about advocacy that you've done throughout your career and kind of how you got started and what you focused on and maybe like what inspired you to do that.
Here's to our Dr. Morrissey. I know you do a lot of advocacy. Dr. Brewer, Kraut, and Barnes, I don't know if any of you do a lot of advocacy. I know that Dr. Morrissey and I both are in that space quite a bit.
Yeah, I started shortly after I became an attending. I took over as medical director for our sexual assault programs and have built that as like a niche. I do that for part of my productive time. Now I'm a division chief. I worked with a lot of community organizations. Actually, last night was we organize once a year a very large event at one of the local universities. We work with, there's like hundreds of college students and then our hospital, that come together, and really we put together these bags that we give to our patients. Like we see 800, 900 patients a year for sexual violence and physical violence. So we connect with a lot of the community. And in that role, I work closely with law enforcement and detectives and DAs, and I work with a lot of community members and have gotten involved in some sort of policy changes. And actually, some of the medical students I've worked with that have come to me that have been interested in working on a particular legislation and working to really increase awareness. And so sometimes it's been like medical student driven, that they've had a particular interest in certain bills that the state is trying to pass. So I've, through some of my interests, have just become more involved over the years as things have come up.
I have a master's in healthcare policy that I got between my third and fourth year of med school. And I got there because when I was a medical student back in the Stone Ages, the FDA was considering Plan B for, pregnancy prevention. And the physicians and the scientists who had studied this said, really our research says that in order for Plan B to be effective, it has to be taken so shortly after the sexual encounter, the unprotected sexual encounter, that it needs to be over the counter or patients won't be able to access it. The odds of you like calling a doctor, getting a prescription, picking it up, it just was not in the timeline that patients needed to be able to access this medication and have it be effective. And so the FDA held their typical expert panel when they have these recommendations from the science world, and 26 out of the 27 scientists said, yeah, this has to be over the counter. It doesn't make any sense that it's a prescription. It's very low risk, very low harm. And the one physician who said, or the one scientist who said, no, it shouldn't be over the counter, was like, it really should be like over the counter, but behind the counter so that, everybody just can't grab it and take it mistakenly like a vitamin. But no one said you should have to have a prescription for it. And then because the FDA is a government appointed head, as it's appointed by the executive branch of our federal government, that person said, that's nice, but it's going to still need a prescription. Because that's where they were at the time. That was the executive branch's privilege to say, no, we're going to just not pay attention to this expert panel. And my medical school student, like colleagues and I were just incensed. We could not imagine that. They're like, why did you ask if you didn't want to take our medical advice? Like, why did you ask us a question? Why have an FDA if you're just going to make kind of political based decisions? And so we brought a policy to the American Medical Association, and CNN picked it up, and they got really excited about how the medical students are challenging that the FDA has become hyper politicized. They got all of our names wrong. They put all these crazy quotes in And then the next day, the president was rolling it back, and the FDA said, we are going to let Plan B be over-the-counter medication. And once you can actually see an effect of advocacy, I'm now a lifer. I will never be able to not do this work that we do ever again. And now I've made a career of it. So what are your other questions?
My other question is, what would you like to see changed in the future of emergency medicine?
Great question. Who wants to take that one?
I'll start.
I love it.
If I had to pick just one thing, there's many, but I think it's a shame that so much of it's all of medicine. It's not just emergency medicine, but we were joking, Natasha, before you got on about how in the pit they don't really show any documentation happening. Nobody's writing notes or anything. And, medicine, we made a few strides recently in terms of how you get reimbursed for ED documentation, but there's so much of your time and energy is tied up in documentation, not to help your colleagues in the future or to write down what actually happened, but primarily for billing and coding and satisfying regulatory agency metrics and things like that. More broadly than just EM, the House of Medicine, I'd love to see a shift toward documentation that's much leaner and more efficient and less oriented toward reimbursement. That and getting rid of private insurers writ large, just having middle folks that are driving this unnecessary documentation all because it's about the billing and the reimbursement.
And I'll piggyback off that, Natasha. So I'm also one of the ultrasound faculty and an inner POCUS nerd at heart. And it's one thing that I'm very excited about that is going to happen and is going to revolutionize medicine. Actually, Dr. Fairbrother mentioned it in the chat, but it is the influence of AI in medicine, right? One of the things that is coming down the pipeline and you're now seeing it start to get integrated, but is the integration of AI scribes to help do our notes for us. In the ultrasound world, one of the reasons I chose ultrasound fellowship is because I love the technology behind it and how rapidly it's evolving in ultrasound. If you look at ultrasound from 20 years ago to now, it's a completely different world. And we're going to look 20 years in the future when everything's going to be handheld, and you're going to have an AI model giving you every point of data possible by particularly getting one image on a patient. I'm just very excited to see where medicine takes us. And I think emergency medicine is probably going to be one of the largest testing grounds for the integration of AI into medicine. And so that's a change that, yes, I'm hoping, but I'm also very excited for it and to how we safely integrate AI into medicine. They're actually looking at building an ultrasound probe in California right now that's a sticker that when the patient comes in to triage, you just stick it on their chest and then you can pull it up at your desk while you're just charting.
That is like Star Trek. That's amazing. Do you have any other questions? We've got a couple more minutes. No pressure. No
I
pressure.
have one final question because I know we'll be at time. I'm a first year medical student, and I was wondering if you have any advice for something that would help me achieve this career that I can look to do while in medical school. What is something that you would advise that I could focus on or get involved in to prepare myself when applying for residencies?
That's another great question. Who wants to take?
Happy to add a little bit of my 2 cents there. If you've got, where are you currently at for school?
I'm at Brown.
Okay, awesome. Great place. And so I'm sure you guys have an EMEG or something similar there. But really, trying to find just a kind of a faculty mentor that's going to do just huge wonders for you. And, I think there's no specialty better than EM. We're all, really outgoing, warm, welcoming. And so if you can find just a faculty mentor that you seem to share a little bit in common with, that's going to go over great for you. And, a lot of people that I've served as mentors for still know to this day. And, they become your partners in crime as you move forward. And so it's pretty great. You get to work with these people for the rest of your careers. But I think that's the biggest thing, is find a mentor, get to know them. They'll show you the ropes, they'll shoot it straight for you, and they'll give you the feedback that you need as you're growing into the specialty. So that's my 2 cents on that one.
Yeah, I also think being able to spend some time in the emergency room. So I actually went to Brown undergraduate and I did some clinical research projects as an undergrad at Hasbro in the pediatric ED there. And that's really what sparked my interest in peds EM. And I met people and stayed in touch with them. So I think networking, but also being able to spend some time in the ED, either shadowing, early on in your student career, but just getting a little more exposure and, working on projects if you're interested in that.
I was just going to say, I'll just give a plug to EMRA as a resource for medical students. It's the Emergency Medicine Residents Association. They're a phenomenal organization. Once I made the decision as a student to that emergency medicine is where I wanted to commit. They have so many resources to helping guide you through every year of medical school and then getting you in touch with mentors, this is a great first step, going to the SAEM panels. But SAEM, EMRA, these organizations have so many resources to help you as a student.
I would just close by saying, listen, we are a flexible specialty. If you look at each of the five of us, we all practice at different places and in different ways and have different niches and different kind of areas of expertise and focus. We also see that in our residency applicants. So there's no program that's, I don't know, you didn't do 10 research articles, so I'm not going to look at you. And then there's no program that says, you didn't have the 2 million on your step 2, so I'm not going to look at you. And then there's no program that's going to just look at one aspect of you and be like, we don't allow for any diversity in this. Actually pride ourselves in our differences, right? We might have someone who's very interested in research. We might have someone who's just got the most amazing scores and is a super academic, like test taking and like academic nerd. We might have someone who is the procedure guru. There's so much space in our field for so many different peoples. I always tell people, like, what speaks to you? What do you love? One of the things I loved was helping women and children who were in domestic violence situations. And so one of the things I did throughout med school was volunteer at a domestic violence shelter. And I kind of did whatever they needed, right? But I longitudinally volunteered. And when I was interviewing, people always wanted to talk about that. I had done a little bit of research and I was a perfectly fine medical student, but I wasn't winning any AOA awards. And that was what was special to me. I was already an advocate. I was already involved in healthcare policy. And so that's what people wanted to talk about. And when I was trying to find my residency spot, you just amplify what makes you tick. And we like lots of different things. You will find your home in our residencies and in emergency medicine with that.
Thank you all very much. I appreciate it.
Well, I'm going to say good night. Thank you, presenters. You're wonderful. Yay, committee, Objective 10. Everyone have a wonderful night. Stay healthy and safe. And thanks for taking care of the people in our ERs.
Thanks.
Night.
Have a good one. Thanks, guys.